So hello and welcome. I'm going to pass the reins over to Bonnie Southgate in a second, but Nikki Scott here, UK Hypopressives, on another UK Hypopressives Q&A and learning a little bit more about hypermobility syndrome, or hypermobility, sorry, and things like hernias, prolapses and breathing. So let me just see whether this works. Make the host. Change host. There we go. It's over to you, Bonnie.
Okay, it says I'm the host now. That's fine. So I'll just really briefly say hello to everybody on here. So obviously I did some hypopressives training with Nikki. And part of the reason I was interested in hypopressives was that I've had multiple hernias, and I have a condition, which is a hypermobility type of condition called EHLERS-DANLOS syndrome. And I wanted to see how it would improve things for me, which it made a drastic difference, if I'm honest, and I probably wouldn't have had my hernias had I done hypopressives first or before. So when she asked me if I would give a little bit of a talk, I thought, well, how can I make it relevant? Number one, to sort of how it was for me. I thought this might be for trainers, so I did gear it a little bit towards them, but I think it should still be a little bit interesting. You may all know friends at least, or you might even recognize things yourself in the presentation. And I'll kind of scoot through the stuff that's less relevant. You might be more interested in the breathing bit, because I think it's quite, breathing in itself is quite fascinating. So I am going to share my screen and let's hope that the presentation all works. There we go.
Oh, look at that.
Hang on. So
it works.
I'm going to play it. It's worked. So that's brilliant. So I'm looking at hypermobility, which may or may not be relevant to any of you, but like I say, you might recognize it in friends or other people. I'll kind of skirt through it a little bit and get on to the breathing, but you know, you may have questions about it later, so we'll move on. So first of all, what is hypermobility? So a hypermobile joint is one that has an excessive range of joint motion. So every joint in your body has an average range of motion, which most people have, and that can be measured and assessed. But some people's joints move way beyond what would be considered the normal range. And that range can really vary. So children are more mobile, and females are more mobile than males. So, you know, we're taking that into account. You can have a lot of range in a joint for different reasons. You can have different shapes of joints. So our shoulders are much more mobile than other joints in our body, just because the socket's really shallow. But sometimes there can be an or you can sort of make your joints lax with stretching of the muscles and the ligaments. But in some other cases, with hypermobility, you can have an increased ligament laxity and a real fragility of the tissues, which is where the sort of hernias, I'll have to admit her for you, because I'm now the host.
Oh, okay. I didn't even see. You'll have to, yeah, you've got to do all that.
That's fine. I'm good. I do plenty of this.
Good. Excellent.
So in some cases, the joint laxity or the hypermobility can vary in severity, and in some situations it can be a sign of a disorder of the connective tissue, and these are inherited conditions, and that's one of the ones that I have. So now change, there we go. So kind of what happens when the connective tissue is altered. There are over 200 heritable disorders of connective tissue. And this means they're inherited disorders, and they're alterations in the genes that are responsible for building our tissues together, our connective. So some of them will change the look of the growth of the skin, the bones. So you've all seen the stretchy man with the skin that comes way out. That will be one of those conditions. But sometimes the different genes affect different bits of the body. It can be blood vessels, lungs, eyes. So anything that's made up of the connective tissue, which is pretty much everything because it holds us together. So some affect joints that are responsible for joint hypermobility. All of them will influence the tissues a bit, which is where the sort of hernias and the things like that come in, which we'll look at. So I've just listed some of the more common reasons for connective tissue disorders that people will see. Lots of them overlap. So I've got that little diagram on the right, and it just shows in the middle a lot of the symptoms overlap from a lot of these different conditions. And we're going to look at just one condition, that's the one in the middle, which is hEDS. We're not looking or spending a lot of time on it at all because I wanted to get on to the breathing. Ehlers-Danlos syndrome. So this is a condition that I have, and which is what made me more prone to the hernias, is one of there's 14 different types of Ehlers-Danlos syndrome. And so they found the genetic cause for most of them, and they all have slightly different mutations in the genes and the pathways. But 80% of the population, EDS population, is made up with the type that I have, and it's called the hypermobility type of Ehlers-Danlos syndrome. And it's the most common type, and actually they're finding more and more and more people have this condition. So probably more of the people that walk in your door, Nikki, may present with this, which is why I kind of wanted to present it, because if there were any trainers on here, if someone comes in with a prolapse or a hernia, then it might be that this is a condition that you might want to look out for, because really they need referral for medical intervention, because a lot of times they don't understand they have it, and they have lots of stuff going on and don't realize it, and it's really underdiagnosed. So I see more and more of it, and we are getting more and more people diagnosed with it. So you can just see the little diagram on the right again, and all the little nice circles are like normal collagens, and then you see the one with the arrow where it's all kind of misshapen, and that's with somebody who's got hEDS. So the connective, it's a bit like a rope frame. It's just not held together particularly well. So these are all the symptoms that come with my condition. So you don't have to have all of them, but you might have them. So hypermobility of the joint, so that goes without saying. You can have, when they say skin stretch marks, they don't mean like with people that have had babies or have gained weight and lost it. They might have really odd stretch marks that have come for absolutely no reason, and they'll be in odd places like the back of a calf. So really strange, odd stretch marks. There will be hyperextensibility of the skin, but not like the stretchy man in this one. So if you have that crazy skin, you don't have this one. Atrophic scarring is scars that sink in. Sometimes you see people and their scars are sinking in. And then you've got what we call bilateral pyogenic papules of the heel. So when I stand up, I have all these little bumps show on my heel, and it's actually, don't be grossed out, but it's the fat coming through, poking out, because I don't have enough holding it in, enough connective tissue. So you get things like that. And then pelvic floor, rectal, and uterine prolapse are very common in this condition, and you can have that in children, men, or women who haven't had a history of pregnancy. So it's something that's really quite common in this group of people. And then hernias. So these are actually on the criteria for diagnosis. And then there's things like dental crowding, narrow palate. Marfanoid characteristics mean extremely long limbs, long hands, things like that. Quite a few people will have issues with heart. Luckily, I don't have any of the heart issues, so I don't have any of the dangerous stuff with it. Soft MSK, so musculoskeletal soft trauma, so things like damage to ligaments or tendons, dislocations or subluxations. I have shoulder subluxations and dislocations. I've had lots of that. Traumas to tissue, pain. A lot of them have acute pain everywhere. There's disturbed proprioception, which means I walk into furniture a lot. So when you find these people, if you're going out with a friend and they're walking in the door frames all the time, then you might want to look at them for this. Flat feet, because the ligaments don't hold the insteps up. So they might look like they have an instep when they're not weight bearing, but the minute they stand up, it flattens out. And then just misaligned bones, because the ligaments don't hold things where they should do.
Very interesting.
So comorbidities are not part of the criteria, and not everyone will have them, but they are something that's seen quite regularly as well with the condition. So sleep disturbance, and a lot of time that'll be because of pain, and fatigue. Well, that goes with the sleep disturbance, but they can often have functional gastrointestinal disorders. They can have lots and lots and lots of gut issues, and that'll be partly because the whole of the gut is muscular and they're not as strong, and all of the junctions are a bit weaker. They can suffer depression. They're often not diagnosed. The average diagnosis is 12 years. So they're really misdiagnosed, because they might go with gastrointestinal disorders as their primary issue, and they're just treated like they have IBS, but it's a very different problem. So they'll have mechanical and nerve bowel dysfunction, and they might have chronic bowel inflammation. Mast cell activation is like an allergy thing. And this is something that's being brought up with long COVID now, is a lot of people are getting this. And it's basically when the body has a trauma of some type, our nervous system goes into fight or flight. So it wants to run from the tiger. And when it does that, it shuts your gut from working down, because it's not useful for you to be digesting if you're going to run from the tiger. And what happens with that is the mucosal lining in the gut, it stops producing the mucus that protects the bacteria from going into the bloodstream. So you get this bacteria going into the bloodstream, and then it activates a reaction to the immune system. So you all are hearing with COVID this overreaction of the immune system, and that's part of it. And that's very common with people with this condition, because they have a lot of things that makes, let me see if I can, is she needing admitting? There we go. There are a lot of reasons for people's bodies to go into this, what we call sympathetic overdrive. What happens is you then tend to get like allergic reactions. So you might get eczema or asthma or different sorts of allergic reactions, and they get really a bit hyped up and crazy. So you get a lot more of this, what we call mast cells, get activated in sending all kinds of things in to deal with all the problems, and then it goes a bit crazy. So things like Chiari type malformation is when the brain sags into the neck, and it cuts off the circulation and the fluid from your brain going into your spinal cord. Lots of fun things with this condition. Luckily, I don't have many of these. Cranial, so instability in the cervical spine. So I know people, and they can end up with serious issues like almost stroke-like problems because their spinal cord gets compressed. Anxiety disorders, well, it's a wonder that they don't all have anxiety if they've got this going on. Myopia, stigmatisms, lots of us have that anyway. A lot of these other people have anyway, which is why they're comorbidities. Poor response to anesthetic. Anybody has a friend that says they go to the dentist and the injection doesn't work? Check them out for this. So they think that maybe the anesthetic gets dispersed in the weak tissue, so it doesn't stay where it should. So they can have poor response to it. It doesn't work. Pelvic floor weakness. So we're going to look at a particular posture after that's quite common in this group of people and in lots of people, but you know, the pelvic floor weakness is a problem. So taking the pressure off it is good, and the hypopressives are really good for that. They can have chronic bladder inflammation that kind of goes with the mast cell activation. Earlier than normal onset of osteoarthritis because the joints aren't held in the right place, so they get more wear and tear. Hormonal imbalances, lots of reasons for that, but they tend to have that. Heavy and painful menstrual cycles, So that could go with the weakness in the pelvic floor, but it could also go with the mast cell activation, because it produces it brings in lots of different enzymes, and it works with hormones and things too. Musculoskeletal complications in pregnancy and cardiovascular autonomic dysfunction. So autonomic, your part of your nervous system, the autonomic part of your nervous system is what controls all the things you don't have to think about, your heart rate, your temperature control, all of those sorts of things. So these people very often suffer with dysfunction in that system. So they can get up from lying down or sitting up, and their heart rate will go up by 40 beats per minute, and it'll stay there. So they've got all kinds of crazy stuff. It's a different way of changing it. So this is one of the ways that they look at diagnosing it. It's called the BEIGHTON criteria. It's only one of many of the criteria. And this is just to assess whether somebody has generalized joint hypermobility. So each limb is equal 1 point, and depending on your age. So if you're young, then they expect you to have 6 out of 9 on the scale. So it's each little finger is 1, and you can see how mine bends back a lot. And then thumbs touching the wrist. So each hand would equal a point if I could do that. So you've got 4 points there. So each elbow, if it hyperextends, is worth a point, and the knees. So the elbows and the knees need to go 10 degrees beyond the normal range to qualify. And then touching the ground with the palm of the hand, not just the tip of the fingers, but the palm of the hand on the floor. So as you get older, because we do get stiffer as we get older, and also they take into account you might get injured. So from teenagers up to age 50, you only need 5 out of 9, and over 50, you only need 4, with other things to get diagnosed. But you know, if you see people that maybe can do some of these crazy things, again, you start asking questions, they might show up quite a few of those other issues. So I wanted to show you this because this is something that a lot of the hypermobiles do, because they look for stability, and they look for stability often around the rib cage, but you'll also see this in postpartum women who've had babies. And there's a strategy for holding yourself up and gripping, and that's in the upper abdominal area. And when you're like that, you can look at this image, it creates pressure down. And some of you may relate to this, because some of you may have had this strategy for stabilization after giving birth, or for whatever reason. And this is chest gripping, and this is an overuse of the muscles around the ribs. So we've got lots of different abdominal muscles, and you have something called the external obliques. And generally, breathing is not good with these people. And they get super tight around the rib cage, and the more tight they get, the more hard it is to get the air out, and the more of a vicious cycle it is. But all of that pressure is pushing all of the contents of the abdominals down onto the pelvic floor, and it's pushing out the belly. So I was a bit like this probably. And you can see how distended the lower belly is from that posture. So I had a lot of pressure on the abdomen. It's like pressure, it's a pressure cooker. So hernias, because my tissues are really weak, were really easy to happen. And I remember doing the training, I had surgery, didn't I, before I was taking my exams. I had to slow that down. And I'm very different now because of the hypopressives, which is brilliant. So this belly posture tends to be in postpartum women, hypermobiles, or athletes that have done a lot of kind of sit-ups and things. And this can also cause a diastasis recti, where you get the separation.
Yeah, I didn't let Hazel look around like she wants to do.
She normally likes to look around. This one is the most busybody ever. She's so funny.
Tell me about it.
She's a busybody.
Somebody,
We had so much fun, Amelia, didn't we?
is that somebody's microphone on, or?
Yeah, you might need to just make sure you mute everybody. I can't anymore because I'm not.
Okay, I'll have to
Just have a look and see.
I might have to okay, how do I escape from this? I'm going to stop share for a second. Now it's all, ooh.
So who's not on mute? So it doesn't look, so Nicoletta's not on mute, so she needs to be muted.
Mute. There we go.
That's it. I don't
She's
know.
the one on her phone. That's absolutely fine. Okay, let's share again. Whoop, there we go, everyone. Play. Oh no, we haven't shared. Ah, escape. Let me reshare. Sorry about this, everyone. Share screen.
There we go.
Okay. Okay, so we'll go on to the next slide. So chest gripping, the ways to improve that is learning to breathe properly. So you're all off to a good start because you're all hyperpressives people. Stretching the upper torso, that's part and parcel of what you do in your hyperpressives. Extension of the upper thoracics over a ball or reaching arms over the head while breathing, or what you're doing in your hyperpressives. Cueing for these clients would start okay. This is from somebody called Diane Lee, who's a pelvic floor specialist in Canada, and her thing is to engage pelvic floor rather than trying to flatten the belly. I wouldn't necessarily agree with that, if I'm honest. And then I've put in here, there's a breathing technique called hypopressives, which is ideal for this strategy because you're taking the pressure off. You're taking away the pressure cooker, basically. So it's not having to overwork. So what we're going to look at now is breathing. And I have a really lovely video, and I want you, I might want to try and play this more than once because it only lets me have a couple breaths. And what I want you to do is, number one, have a look at the diaphragm, which is the bit at the bottom when it breathes. But after that, I want you to have a look at the heart, and I want you to have a look at the arteries going up into the neck. You can see what the ribs are doing, because when we breathe, it is not just about getting air into our lungs. And that good breathing into the thoracic rib cage does all kinds of things to us, which are beneficial. So yeah, have a look at that heart and the lungs. Huh?
It's amazing.
It's amazing, isn't it? And I'm going to go back and we're going to play that again. So I'm going to play it a couple times because there's so much to take in when you look at this. So, you know, start with looking, you can see what you're seeing down here is the liver and the organs, well, the diaphragm, and the heart is attached to the diaphragm with a ligament. So when you breathe well, it's helping your heart pump. And then if you look up here, you can follow my hand here. You look all the way up and the arteries going up into your neck and your head and brain. It's affecting the blood flow all the way to your brain. So I'm going to play that one more time. So have a look. It's the second breath is a bigger breath in. Those ribs go up and out, and the stretch on the heart and everything all the way up the chain. It's quite amazing, isn't it?
I need this video.
It's a fantastic video to really give you the concept of how important breath is in the whole system. So breathing, the act of controlled breathing, which is what we do to benefit health, has been practiced for thousands of years by Eastern cultures. Slowing breath and focusing on diaphragmatic breathing is not a new idea. The question is how and why does it work, and how can we use it to help hypermobile or our normal clients who suffer from hernias and prolapses, which is what this was about, and which is what maybe what you people have come to Nikki with. So the diaphragm is considered to be the main muscle for respiration. And there's also secondary accessory muscles, which are the external and internal intercostals. And those are the muscles around the ribs. So those are the ones that open and close your ribs for you. And then you've got the ones in the neck. You've got ones that come down from behind your ears and into the upper collarbones. That's your sternocleidomastoid. And scalenes come from your neck into your upper ribs, and they try and help to lift up those ribs. And these make up what's known as the respiratory pump. So the external intercostals, so those are ones in the ribs, help with lifting the ribs. and the diaphragm contracts. So the diaphragm looks like a big mushroom, and it's the sides of the mushroom that come up. It's like an umbrella. So the sides come up and it comes down and flattens out and it pushes down. So it was pulling on the heart when it did that. It was really extraordinary. And so this, when it does it, it creates almost like a suction that pulls air into your lungs. So it helps you to get that air in when that works. When that's not working, you get a little bit of breath at the top of the lungs. You don't get any of the help with the heart. You don't get any of the pull on the vascular system. You don't get any of those lovely benefits that you get when you get that diaphragm working. So, you know, it's so important. And it's creating that vacuum effect for the lungs. So we've got some of the muscles. These are all those muscles we were talking about. Exhalation is generally more passive. Now, it doesn't have to be, and like you practice, you can extend that exhalation and you can make it more active, and there's nothing wrong with that. It's just strengthening up more of the muscles. So in your daily breathing, when you don't think about it and you're using the diaphragm for inhalation, it recoils, rises back up, and the internal intercostals bring the ribs back into place, and the air gets sent back out. So the expiratory muscles become more active, including the abdominal muscles, which pull the abdominal wall inwards, forcing the diaphragm up, helping to deflate the lungs. So when you're in a state of that fight or flight, when you're running from the tiger and you get stressed, your breath tends to get shorter and less deep. And then people hyperventilate, don't they? And then you tend to recruit more of your neck muscles than your diaphragm. So you miss out on all those great things that help with the vascular system and everything else. So breathing, now this is getting a bit technical because I might have pitched this for the trainers. So we have something called chemoreceptors. So they're just receptors, and they influence the rate that we breathe because they monitor how much oxygen we have in our blood. Well, we have other receptors, which are called baroreceptors, which monitor our blood pressure. So we have all these receptors monitoring for us all these things. And together, these things monitor like how quick you breathe, how much you breathe, and at what rate, in order to keep the homeostasis of the oxygen to carbon dioxide and to keep the heart rate where it should be. So when our breathing is slower and the muscles are more relaxed, the volume in the lungs tends to get larger. And as you saw in that video, the larger breath had a larger impact on the heart, where there was a greater pull on it. So the baroreceptors monitor pressure through the stretch of that. And so the deeper and the longer the breath, the more they receive signals that there is volume in the system. So if you have a shallow breath, if you're not a good breather, you're not really getting good feedback into those receptors. So you don't get as much feedback about what's going on in the heart. So there's also new research that looks at the role of the heart and the diaphragm and their influence on different systems. So when the heart contracts, it's able to influence the brain. So it influences the brain by moving it in. So caudal is towards your tailbone, and that's downwards. So when your heart contracts, it pulls your brain down and it affects the flow. So we have around our brain, we have something called cerebrospinal fluid, and it washes your brain out and it takes all the bad bits out of your brain. And then it also comes down your spinal cord and it lubricates your nervous system. So the diaphragm is also able to influence this on exhalation. The brain is pulled down in that direction on inhalation and returns up on the exhalation. So your good breathing helps to take all the rubbish away from the fluid in your brain, and it helps to keep the flow of that system, so the lubrication of your nervous system, also better. So, I mean, it goes way beyond we're helping hernias, we're helping prolapses, we're getting oxygen in. This is major for the entire system and the health of your entire body and nervous system. So while the heart helps move the cerebral spinal fluid faster, the diaphragm influences the quantity of it, which is moved. So it all works together harmoniously. So the contraction of the heart, get this, also influences your optic nerve. So you saw that pull, didn't you? That goes all the way up to the back of the eye and the nerve. The head of the nerve moves with a heartbeat. When the heart contracts, the optic nerve is stretched. The constant stretching helps create substances that improve the vascular supply to the nerve in the back of your eye. So your eyesight is also drastically affected. So there is a relationship to the whole system. And nasal breathing, it is best if someone can inhale through their nose. So when you nasal breathe, it stimulates something called the glossopharyngeal nerve, which is a nerve in the back of the nose, which has a connection to something called the vagus nerve. And the vagus nerve is the one in control of your fight or flight or your rest and digest. So it does all of the monitoring of like your mental, your state of being. And it has a massive impact on our systems. So that nasal breathing really helps to calm the whole system down, and to provide an easier access into your good breathing. So that nasal breathing will help to calm and slow the breath down. So heart regulation, good diaphragmatic breath can be important to somebody who's got, we talked about dysautonomia. So that's when the autonomic nervous system doesn't do its thing. It doesn't regulate things well. Breathing along with a good, strong heart improves a lot of the functions in the body. And the better its function, the happier the nervous system is. So pain, gut problems, just everything, your whole health will be influenced by it. So how should we teach our clients to breathe, or how do you want to breathe? So there are studies that have looked at breaths per minute, and a normal breathing pattern is anywhere from 10 to 20 breaths per minute. So to be really beneficial with breath training, they looked at 4 to 10 breaths per minute. So slowing it down, basically. So everything you do in your hypopressives. So it's going to make sense to you, Nikki, how fantastic what you do is. You know, so the research is out there saying that there's, you know, you take it, the slower you take it down, really almost the better it is. But they say this is only beneficial if the tidal volume can be increased. And the tidal volume is when the diaphragm allows the air into the bottom of the lungs. So if you slowed your breath down, but it was still up top here, you wouldn't get the benefits that you do when you get that big rib cage moving, and that allows that tidal volume to be bigger. So the alveoli are bits at the bottom of the lungs. They need to be able to open and stretch to get all these big benefits from your breathing that you do. So everything you do in your hyperpressives is perfect. So using certain breath techniques, some of which include holding your breath, can lower inflammation. I found that research out as well. So that apnea breath at the end might actually lower inflammation. And also exercises that involve holding the breath for several seconds can be part of regular relaxation practice and may help improve the health of the cardiovascular system. So there you go. How fantastic is all of that?
Amazing. Amazing.
And I've just finished with that image again, so you can have another little look. And thank you all for listening. That's the end of the presentation, but look how
that's fantastic, isn't it?
See it all happening, can't you?
It's just brilliant, that image. I need to get that video. Well, I've got your presentation, so I'll be watching that. That's just wonderful.
There we are.
Well, that was pretty amazing, I think. I really enjoyed that. It was really some really amazing information there. I learned a lot myself. So I'm going to open the floor up to questions. So if you've got a question around anything to do with that, then maybe just put a reaction up. So at the bottom, you've got some reactions. So you can do a wavy hand, a smiley face, whatever, and we will come to you when you've worked out where those reactions are. So if there's anybody that's got a question at all.
Claire.
Yeah. Hi, Claire.
Hi, that was great. Thank you very much. Can I ask, do you adapt your physical postures at all with regards to your hypermobility when you're doing the hyperpressives?
Yeah, really good question, actually. Yeah, I did a little bit. I struggled sometimes with the shoulder stuff when we were kneeling. They just didn't want to sit in the right place. And I have to be a little bit careful because I can dislocate them. But I mean, that was fine. Nikki, you always were just like, do what you can.
Yeah,
You know?
absolutely.
I think the only other thing like I would watch out for with the hypermobiles is they can get a bit overzealous trying too hard and they can really grip stuff because there's not much feedback like proprioceptively on contraction of the muscle. You can overgrip, so I would be just a bit careful with that. But you know, there's not much in the hyperpressives. I wouldn't, if somebody was so with the hypermobility, sometimes they can struggle with severe headaches all the time. I probably would be careful with them as a group because they can have cranial brain issues. But you still, you know, you would still be aiming for this kind of breathing. In general, hypermobiles hold around the rib cage. They hold there for stability. And I would say out of the people that I see, because I run a clinic, a rehabilitation clinic where I am, almost all of them need breath retraining.
Yeah.
So,
I mean, getting away from hypermobility, I think that just generally as a population, we all need breathing training.
yeah. I think the only other thing I watch is sometimes they try and really grip between the shoulder blades. So I would watch, like, if you are training them, that they're actually using their extensors, like their backs, rather than gripping in between the shoulder blades, because that's a strategy that we use a lot to keep their shoulders on.
Okay.
And that's not great for them. So, like, you would have to watch that they're not cheating in that way.
Yeah.
Okay, thank you.
But aside from that, not really.
Okay, great, Claire. Thank you.
Thank you.
Raquel, can I come to you? Because I know that you've come on this specifically because you've got hypermobility.
Yeah, and it's been great because in the last almost weeks, I've been hearing so much about this breathing. And I mean, I have friends reading this Oxygen Advantage book and telling me how important that is. And also some of the friends doing this Wim Hof method. Yeah. And I don't know, I think it's about holding your breath and also telling me how important that is. So that was great because I could see that so well here. Another thing I wanted to ask, for example, I breathe through my mouth, but I don't know how to stop that because that's a very bad habit, and especially in the night, there is no way. I don't know if anybody has any way, any things they've done to be able to correct that, because that's really something I know is not good, but very difficult to change.
Yeah, so do you actually struggle to get air in through your nose? Is it like
it's more like, yeah, sometimes because it's not enough air, but some other times it's just a bad habit of breathing through the mouth and sleeping with your mouth open and doing things with your mouth open and even exercising with your mouth open. So it's like quite difficult to change.
So do you know you have a hypermobility issue?
Yeah, I have hypermobility. I mean, normally it's funny when you're small, they send you to ballet and gymnastics and everybody thinks you're great because you can do all these things, and yoga, everybody looks at you. But now with age, yeah, that's another question. I mean, do you have any other things? I mean, I know exercises are important. I do Pilates and yeah, but still.
If you struggle to breathe through your nose and you're hypermobile, it could be a jaw issue.
Yeah, like
there's a lot of, I mean, there's a person in pool, there's a specialist in pool who does a lot of either giving, because sometimes you can have an unstable jaw and it can fall back and do funny things, then it compresses bits. So he gives like almost a mouth guard to pull it forward. And he has a wife who does lots of mouth oral exercises.
So that's interesting. So
I mean, there are people that also they suggest taping the mouth shut.
I've I bought something like you could just put on your mouth, but it's very annoying.
So my thing, Raquel, would be just try and do the nasal breathing when you can, when you're awake, and actually don't worry about it at night, because it's probably better than clenching your jaw.
Yeah, worrying too much is also not a good thing. And the other question is, any other advice that you have? Because I mean, with age, I do Pilates and all kind of exercises to be strong and to hold the joints. So that's
I have lots and lots of things. I've got a Facebook page which is Hypermobility Exercise and Education.
Oh wow, okay.
Which I was going to give you the links, and I just didn't get around.
That would be great, but there is not so many people talking about this. It's most of the times you have to look for things yourself, and it's nothing.
Where are you based, Raquel? Where are you based?
In London.
I mean, there's support groups and things as well.
Yeah, I have to research more, I guess.
Well, Bonnie, you can share your Facebook group with me, and I'll make sure that I post it out to everybody.
Okay.
So
I mean, you're welcome to have my email address, Raquel, as well. Because I'm happy for you to Zoom meet me if you have particular struggles. I run a support group, so I'm doing that all the time for certain bits of your body.
Yeah, that's great, because I know it's genetic, because I had a child, and now the pediatrician already told me she has issues in the ankles, and she walks like this, and my father also had lots of hernias, so I know it's something running in the family. So thank you. If you can share that would be great. Yeah, thank you.
You're welcome to share my email.
Yeah, I'll send over you Bonnie's details for you if you want, Raquel.
Do you think, just last question, do you think migraines could have something to do with that as well, or is something?
Your what?
Migraines, like headaches, like.
Oh, it's all connected. It will all be connected.
Yeah, and I mean, I have headaches with vomiting and all kind of things, like really, really bad. So I
think we need a conversation, Raquel, about everything.
All right, thank you.
Definitely. So, I mean, try the hypopressive, see how your headaches go. You don't want to bring a headache on. And that's an unknown, because sometimes they can have, with hypermobility, you can have pressure buildup of fluid in the brain, or you can have too little. So it can make some people their headaches better, or some people worse. So it's a try it and see.
Yeah, I think depends on the day. Sometimes it's better when I do some breathing exercises, and some other days it goes worse. You never know which way it goes.
Okay, well, I mean, we could assess you and things like that.
Thank you.
It's all right. Yeah.
Okay, has anyone else got any more questions? There's lots of you here. Vanessa, have you got a question?
We can't hear you.
We need to, if that's it.
I'm muted. Really, just where can I get more information? I'm not specifically hypermobile. I am very flexible.
Okay.
But I'm also quite old. But I'm a ballet teacher, so come across these kids throwing their legs around and doing all weird things.
The only other thing I would say, I do run I have a course. Which it could be an online course. I haven't done it in person because I set it up over COVID, and I did it over 4 half days, which is available. I probably will run an in-person course probably, early in the new year, if you're interested in that. I'm Dorset.
Right. Okay.
Where are you based?
I'm Hampshire, Surrey border.
Okay, so you're not too far away.
So another thing I was going to mention as well, Vanessa and Bonnie, is that next year we're going to starting to put together some CPD stuff as well. So I was going to ask Bonnie to do some stuff for that as well, Vanessa. So it might be something that
you might be interested in the online, because it's going to be cheap anyway. But it's super comprehensive. There is not another course out there like it for hypermobility.
Amazing.
I definitely know that, because I know what's out there. I'm also writing a book at the moment on the management of it, which I've nearly finished.
Wow. Busy
which
lady.
is taking me almost 2 years. It's a huge subject. So But you do need to watch out for it, Vanessa, if you're a dance teacher, because
All the time.
these days it's
Really hard to kind of get those students who are, I don't know, between the age of 10 and 16 to accept that they've got to learn the strength. They just want to throw their legs.
I know.
Splits left, right, and centre, and not learn to control it.
There's some little, I mean, again, if you want to give her my email, there's some little tips as well that I can give you in terms of maybe some exercises to be beneficial to kind of save their hips and their feet, and which I wish I had, because I'm ex-ballerina. I dance with Royal Ballet, and I ended up with 3 operations on my feet, which I think all could have been avoided with what I know now.
Thank you.
Brilliant. Thanks, Vanessa. What I will do is, if you would like Bonnie's details, if you just send me an email after this, it's just nikki@ukhypopressives.com if you haven't got my email address, and then I'll make sure that you get Bonnie's details so you can get in touch with her and get sorted. But yeah, that was absolutely amazing. I really enjoyed that. Really, I'm going to watch that back, because it was really very interesting, and there's kind of a few things there that it's a real you know, there's so many symptoms, isn't there?
Yeah, lots.
So many things.
I really have barely, we have scratched the surface there.
Yeah. Wow. I need to learn more, definitely. Amazing. So if everyone's good to go, thank you very much for joining us this evening. And thank you, Bonnie. That was amazing. And I will see you all again soon.